Thank you very much, Jasmin, for the wonderful and kind introduction. It's my pleasure to be here this afternoon, ladies and gentlemen, to talk to you about a new kit on the block in the prevention of shingles, a new recombinant zoster vaccine, and in the background of immunosenescence. So these are my declarations. Now, this afternoon, I'm going to talk to you firstly about the impact of shingles. We tend to forget some of these things, but reiteration on why is it so important thereafter to vaccinate adults who are more than 50 years of age. I will also then be dealing with what the clinical profile is of this new kit, which is Shingrix, and then how we should perhaps think of ways to implement Shingrix in the clinical arena. So what is the impact of shingles on our patients? So let's illustrate this with a case study. This is a 68-year-old gentleman who is a patient of mine and a businessman who had the past history of the following, which included diabetes, hyperlipidemia, hypertension, and ischemic heart disease. He presented with acute pain over the left forehead, headache, followed then by the rash that you see on the photo on the left, followed by left eyelid swelling and blurring of vision. So what he had was left trigeminal herpes zoster with herpes zoster ophthalmicus complicated as well by preseptal cellulitis and post-herpetic neuralgia to boot thereafter. His treatment included standard of care. We had to give him intravenous in view of the severity of infection. He also needed a course of antibiotics for superinfection, as well as local ophthalmological therapy, including gut steroids. And then, because of the post-herpetic neuralgia, he required pregabalin, which is also Lyrica. So this case is, in a nutshell, illustrating the complexity of cases with severe herpes zoster that you and I may have seen. In the context of morbidity, in the context of opportunities lost at work, he's a businessman, so on. Hospital length of stay, cost involving multiple different specialists, internist or ID physician, in this case ophthalmologist, as well as a pain management doctor as well. So in all these contexts, he also had to suffer post-herpetic neuralgia. But if you think about all these, it's a very vaccine preventable condition. So all this could have been prevented. Now, 99.5% of adults more than 50 years of age are infected with herpes zoster virus and are at risk for shingles. When you get varicella, perhaps at some time in your childhood, you get control of the primary infection, but subsequently there is a latency of the virus in the dorsal root ganglion. And when there is reduced immune control, then it begets virus reactivation and hence the manifestation of shingles or zoster. Up to 1 in 3 people will develop shingles in their lifetime due to VZV reactivation. And the incident rates are similar between countries with an overall of approximately 5 per 1,000 person years in Asia. Locally, in Singapore, there are an estimated 30,000 new cases of shingles every year. Now, shingles can be a painful disease and it can cause serious and long-lasting complications. Its acute presentation, just a reiteration, unilateral vesicular rash, and the rash can be excruciatingly painful, described as a stabbing, burning, achy pain or shock-like pain. And of course, you can have other symptoms as well, photophobia, malaise, fever, and so on, headaches. Complications will include a few, primarily post-herpetic neuralgia, which I'll refer to that as PHN from now onwards. And PHN is a neuropathic pain that persists for more than 3 months, and it can affect up to 30% of patients with shingles. Herpes zoster ophthalmicus affects up to 25% of patients with shingles, and it may lead to vision loss in some rare cases as well. There are, of course, other complications, including disseminated disease, especially in immunocompromised patients. Some unfortunate individuals may have hearing loss. There's also scarring, a bit of a cosmetic blemish, neurological complications, as well as cardiovascular and even cerebrovascular events. Now, unfortunately, about 5 to 10% of patients can experience recurrence. Now, with all this said, herpes zoster symptoms and complications are frequent and have longer duration. Unfortunately, they are amplified in immunocompromised and vulnerable hosts. Now, a little bit more about the post-herpetic neuralgia pain that can come as a result of shingles or shingles pain itself. If you look to your left, you will find that there is this specific questionnaire, which is a pain questionnaire for acute and chronic pains. And if you look at where herpes zoster stands, it is actually above a few things that you may correlate to, which is post-surgical pain and even sometimes labor pain. And if you look at post-herpetic neuralgia or PHN, it sits above pain associated with a lot of arthritis. Now, more than just the rash itself, herpes zoster can be very debilitating to individuals. If you look at the right, you will see a pictorial on how about 260 over persons who had newly diagnosed shingles were followed up with some questions with regards to how shingles affected their sleep and so on. You can see how it impacted quality of life, not just enjoyment and general activities of living, but mood and so many things, including walking abilities. So it's something that we all want to prevent, not just for the reasons mentioned. So why do we come to this point about why is it important to vaccinate adults more than 50 years of age? Well, the burden of shingles increases with age. That is the immunosenescence that we'll be discussing in a bit, with a sharp increase from the age of 50 years and above. This data represents countries from around the world, not just in the Western Hemisphere. UK, US, Europe are represented here, as well as some countries in Asia. And what it represents is incidence rate as a function of age. And you can see the precipitous rise in the context of age 50 and above. So more than 90% or about 90% of subjects who develop shingles are actually immunocompetent. So even though we worry a lot about immunocompromise, if you look at all the different age groups that may encounter and sustain zoster, the risk for herpes zoster is still higher in immunocompromised people, but the burden of the disease is actually significant in otherwise healthy people. So this concept of immunosenescence or age-related decline in immunity is the dominant driver of shingles. Now, if you look at this, it represents cellular immunity as a function of age with a so-called shingles threshold. And when you had chickenpox, you will get primary VZV inducing specific immunity, cellular immunity. And this VZV, specific cellular immunity, may be boosted periodically via VZV exposure or silent reactivation from latency. And that can prevail. But when you get older, there is a dip. That's when people start to get older than 50 and so on. This VZV specific cellular immunity starts to decline. And that decline will then beget increased risk from shingles. Now, on top of that immunosenescence with regards to age, common comorbidities further amplify the risk of shingles. There is an approximate 20 to 30% increase in zoster incidence risk with cardiovascular disease, a 30% increased risk with asthma or COPD, and a 40% increased risk for diabetes. Patients with multiple or stacked risk factors have a higher risk of shingles. So just imagine for those who are 50 years and above, the lifetime risk of shingles is about 30%. But with diabetes, this is further amplified to 40%. With cardiovascular disease, 20%. So on top of age, multiple comorbidities of diabetes and cardiovascular disease have an additive effect, and the increase of zoster then rises to 60%. The treatment options for shingles and its complications have limitations. When the rash appears, the antiviral treatment is of course important, and that's what we do for acute zoster. But to get the best results, the treatment should be started within 72 hours of rash onset. Many of our patients don't come that early. Many think that they have some other problem and they try to wait it out. By the time they see their general practitioner, it may be several days out. And also remember that antivirals can reduce zoster severity and duration. However, oral acyclovir does not impact on the post-herpetic neuralgia incidence, and there is insufficient evidence for the other antiviral therapies. The rash can last for 7 to 10 days, and this management of herpes zoster pain starts at this point, and it can therefore last for longer periods subsequently. And patients with PHN may need multiple different types of pain controlling meds. We spoke about my patient in the case study who required Lyrica, but there are other types of medications, tricyclic antidepressants, opioids, and so on. But even in those who have PHN, only about 14% of patients are actually satisfied with pain management. And this is actually very true. And I have several patients who continue to experience discomfort years after the original event. So what can we do about this? Well, we try to prevent it with a vaccine, obviously. So we had a live attenuated vaccine. This live attenuated vaccine had been available locally since 2008. It's indicated for the prevention of shingles in individuals 50 years and above. But the live attenuated vaccine, simply because it's a live vaccine, is also a problem. There is a disseminated disease that can occur in people who are immunosuppressed or immunodeficient. So therefore, it's contraindicated in such individuals. So the background with regards to the live attenuated vaccine rested with 2 studies, and I will just get through briefly with the ZEST study on your left and the shingles prevention study on your right. So in the ZEST study, adults who are 50 to 59 years of age were compared to placebo with live attenuated vaccine. And you can see for those who are 50 to 59 years, the vaccine efficacy was about 70%. The vaccine efficacy against PHN was not assessed in the ZEST study. For the shingles prevention study, adults 60 years and above, the vaccine was compared with placebo, and overall the vaccine efficacy was 51%. But if you stratify that by age, you can see that it started to dwindle in the elderly, like 70 years, you will find the vaccine efficacy was only 38%. And that for post-herpetic neuralgia was about 67%. So we now come to the clinical profile of Shingrix. So what is Shingrix? Well, it was designed to help address some of this age-related decline in immunity. We spoke about that earlier in older adults. So it's a recombinant varicella zoster vaccine comprising a glycoprotein E antigen with an adjuvant with an ASO1B system. So the glycoprotein E elicits a specific immune response against varicella zoster virus, which is the primary target for VZV specific immune response, and it's expressed on the surface of VZV infected cells, which is a key to viral replication. The adjuvant system is designed to induce strong and sustained anti-glycoprotein E immune response. The combination of the MPL and QS21 within the adjuvant system enhances both antibody and cellular immunity response against the glycoprotein E. So in this pictorial, you can see how adjuvants help to generate a strong and long-lasting immune response. Because when you have an adjuvanted vaccine, this is the immune response over time. You get a stronger, broader immune response in the beginning, which then leads to a longer immune response as compared to a non-adjuvanted vaccine. Shingrix was investigated in 2 large pivotal phase 3 clinical trials called the ZOE50 and the ZOE70. These were randomized observer-blind, placebo-controlled, multi-center, multinational studies across North America, Europe, Latin America, and the Asia-Pacific region. ZOE50 looked at efficacy in persons more than 50 years, and ZOE70 for those who are more than 70. So the dosing schedule was vaccine or placebo administered intramuscularly, 0.5 mils at baseline and at 2 months. And the primary objectives was to look at the efficacy against post-herpetic neuralgia in those who are 70, and pooled analysis also looked at efficacy against zoster in the same age group. So the total vaccinated cohort in the pooled analysis was in excess of 17,000. So for those who were in the Zoe 50 study, Shingrix delivered a more than 90% efficacy against shingles. And if you look at the stratification by age, you will find that it was rather consistent, 97, 96, 97.4, 97.9, even with those who, in those who are 70 years and above. If you look at the pre-specified pool analysis of both Zoe 50 and 70, you will find that those who are 70 and above, the efficacy was 91%. And again, it was consistent across the age groups, the older age groups. So this was quite good to see. Now, by preventing shingles, Shingrix significantly reduces the risk of PHN and other complications. So on your left, you will see the vaccine efficacy against PHN for the one in red, which are those who are 50 years and above, which is 91%, and for those who are more than 70, which is 88.8%. On your right, you can see the vaccine efficacy against other herpes zoster related complications. This was a post-hoc pooled analysis. And for those above 50, it was 93.7%. And for those who are more than 70, 91.6%. We also tend to be worried whether or not this data can be extrapolated to our geographic area, because a lot of the studies we think may be done in the context of races other than Asian adults. And so this is a study that looked at the context of a cohort of patients who were in the Zoe 50 and 70, and Shingrix showed similarly high vaccine efficacy in Asian adults, with more than 90% of in all age groups of Asian adults, and efficacy prevailed at 4 years at 94.7%. We also want to know how long can the immunity or the protection last. That's very important to know as well. So the long-term follow-up study interim analysis showed sustained efficacy for more than 7 years. So the one in blue, the arrow shows that it is been studied for 7 years since the start of the Zoe 50 and 70 studies, which was 90.9%. Now, some of the vaccine patients who got the vaccine in the Zoe 50 and 70 studies were subsequently re-enrolled into another study called the Zoster 049, and this is planned to be extended till July of 2023, and it started in April of 2016. The interim analysis was slightly more than 2 years after follow-up in this, and it showed a vaccine efficacy of 84%. So that study is ongoing. So it still tells us that the vaccine has got a very good protection despite more than 7 or potentially even 8 years of follow-up. So now we come to this big thing about the local adverse events. You may or may not have heard quite a bit about this. So this is a solicited local adverse reactions reported up to 7 days post-vaccination. And you can see representation of pain, redness, as well as swelling. And you can see how disproportionate it is for those who are given the vaccine, whether in the Zoe 50, 70 studies, as compared with placebo. So it's true, there are quite a lot of local adverse events, but bear in mind that the median duration of these were 3 days or less. This is to tell you about the solicited systemic adverse reactions reported post-vaccination. You can see fatigue, fever, GI symptoms, headaches, myalgias, shivering, again, all in proportions that were skewed towards the vaccine as compared to the placebo. Now, forgive the bubble, the blurb is wrong. It's actually median duration of systemic reactions, not local. It's also approximately 3 days or less. So it's not like you're going to get these symptoms to be going on for a long time, but you have to bear in mind that there are some of these local and systemic events which can come about, but they are not serious. So the safety results support the favorable benefit-risk profile of Shingrix in adults more than 50 years. Now, why do I say that? If you look at severe adverse events, fatal adverse events, or um, possible immune mediated diseases, you will find that there is no difference between Shingrix and placebo. So what we have is that Shingrix was comparable with placebo in overall incidence of severe adverse effects at 1 year post-vaccination, and the vaccine compliance was high at more than 94%, with almost all participants returning for the second dose despite the local side effects. And it's got a similar safety profile in Asian populations as well. So the last part is the implementation of Shingrix in our clinical practice. As you can see from multiple international guidelines, Shingrix has been recommended across several countries, either as a primary recommendation or a preference over the live vaccine. Shingrix is indicated for the prevention of herpes zoster and post-herpetic neuralgia in adults 50 years and older. It's contraindicated to those who have any hypersensitivity to the active substances or any components of the vaccine. Is given as a 2-dose series, administered 2 to 6 months apart, and it's only intramuscularly injected. Those who remember the live vaccine may recall that that is given subcutaneously. It's applied in 2 vials for reconstitution. 1 vial of antigen should be reconstituted with 1 accompanying vial of adjuvant suspension. Shingrix should be refrigerated, do not freeze it. Store it in a refrigerator with the standard temperatures of 2 to 8 degrees. And after reconstitution, Shingrix is stable for 6 hours when kept in a refrigerator. Shingrix has a shelf life of 3 years. And we worry sometimes about co-administration, but this is just some reassurance that it can be safely co-administered with the unadjuvanted seasonal vaccine, seasonal flu vaccine, as well as the pneumococcal polysaccharide vaccine, or the Boostrix or Tdap vaccine, but you just need to administer them at different anatomic injection sites. So there is this caveat, we always talk about the COVID-19 vaccination and how we should be spacing it out with regards to other vaccines. Though the Ministry of Health has recently endorsed flu vaccine that can be given within 2 weeks. More data may evolve on the safety of giving other vaccines as well. But as a stopgap measure, if you want to sequence the Shingrix and your patients who may require the COVID-19 booster shots, these are some examples that you can think of. So you can place your Shingrix first and second doses in between your COVID-19 boosters, like shown in the first part or the one below. You can place it in between the shots. You just have to try to figure out a way that you interval it between 14 days between the shots of the COVID-19 and the Shingrix shots. So implementing Shingrix into practice. So this is the challenge. How do you incorporate Shingrix into your day-to-day discussions with patients over 50? I think this is always a problem in busy clinics or in the inpatient ward settings, because you have so many distractions and, but I think it's important to also bring it back to our own lives as healthcare workers. Many of us are not as young as Jasmin. And so we also think about our own risks. We want to take our much wanted holiday and the VTL across to maybe the epicenter of COVID in Europe or some other parts of the world where we don't want to be afflicted with zoster when we're enjoying the ski, the Alps and something like this. So if you're convinced as healthcare workers yourselves that you ought to get the vaccine, then I think you will do a pretty good job in influencing your patients as well. Of course, you have to take a step back and look at the other occasions when you talk to your patients about vaccines, because you also have to talk to them about the flu vaccine, COVID-19 vaccine and boosters, and also the pneumococcal and whatever. So many times when they come to meet you, when they are much better from their clinical syndrome in the hospital and meet you in your clinic, that's a very good opportunity to bring up this discussion. You can also leave some pamphlets and educational posters outside in the clinic waiting room or in the busy hospital setting along the walkways and so on, because these are points of discussion which your patients can actually bring up with you rather than having to always bring it up yourself and trying to stress yourself or your staff. So a lot of pictorials can help, and in my own experience, I feel that actually helps a lot because patients are waiting and they pick up things to read and then they bring up the. The other thing is actually to talk to caregivers. Very often patients who are elderly, they don't make decisions for themselves and you need caregivers, and the caregivers frequently come to you now in the setting more than ever in the outpatient setting because of visitor restrictions in the inpatient setting. So for those of you in primary health, that is the better way. You can meet the caregivers and educate them because the patient themselves may not be so well versed in all these things, and the science and all these may be lost on them because they will say, don't talk to me about this, please talk to my relatives and so on. So there are various examples in which you can try to bring up this. Now, how will you approach the fact that the vaccine is a new vaccine with an out-of-pocket cost for your patient? The new vaccine component is always a challenge because, people are already so worried about the COVID-19 vaccine, and we had such a difficult time with vaccine hesitancy, which continues to prevail in small pockets of the community. So I think you have to bridge that gap and talk to them about what has already been known about the platform of subunit vaccines. This is tried and tested and true, and that you have a lot of good safety data in this regard. And the fact that this cost issue is something that is still evolving because, as you know, this is not a cheap drug, a cheap vaccine. Am I about to say that? The cost will be modified for you, okay? But anyway, it will be something that you have to discuss in the context of how the patient is going to pay, whether there are some paymasters or whether the patient is seen in a different setting. Like for my practice, I'm in the private sector, so it may potentially be a bit more easy for me to give the vaccine. But then again, for the undifferentiated world outside in community settings, may not be so cost effective. And so we look forward to more cost effective studies in this regard. But still, if you look at the other side of the coin, the case illustration that I brought up brings forth many painful issues for you. For example, your patient may lose time off work, hospitalization costs. That is cost. How do you account for that? That's actually something significant. You have to have that discussion with your patient as you move along, and further modifications can be done in the future with regards to how certain costs can be reimbursed for such vaccines. Now, how do you discuss the safety and reactogenicity profile of Shingrix with your patients? Granted that approximately 1 in 6 of the patients may experience some form of local or systemic reaction, you have to educate them about that because we spend a great deal of time trying to tell patients, especially in this COVID era, because you get a fever, you get out of sorts. That becomes almost like a mandatory testing for COVID-19. You will be barred from coming into this conference venue, for example, and so many things. So you have to try to tweak the vaccine in the context of the life, the work of the individual. Maybe they need to get time off or they need to be over the weekends because you can't predict who might get those. But I think it's our job as healthcare workers to understand the science and to convince them that those kinds of safety, the safety, the benefits far outweighs the risks because, as we can tell you quite convincingly, although it's quite reactogenic, the symptoms don't last long, 1 to 3 days, So I think it's something that can be surmounted. And as far as the data is concerned, I know these were the pivotal trials and so on. We did get a great deal of compliance. But I think for those people who are dropping off after the first dose, this is when it comes to you or your other ancillary staff to try to inform the patients through various platforms that this is expected. Understand that this is not a bad reaction. You should be fine, and so you got to do some education. Okay. How do you ensure the compliance with the 2 doses? So this is where you have to tell the patients, nobody likes to get the side effects and be told subsequently, oh, this is normal, because you can't just in your busy practice, and so or so you've got to tell your patients, you've got to engage their caregivers and make sure that they understand this part of it. As long as the patients know that this is expected and this is short term, it doesn't preclude the second dose. And it's an expensive course at the moment. So if they have to do a lot of out of pocket expenses, you seriously want them to get the second dose to make sure that they have the prevalent immunity that can prevail over the what we know 7 to 8 years from the vaccine course. Okay. So I hope I have given you a summary, a brief on the agenda that I wanted to discuss with you this afternoon. That up to 1 in 3 adults will develop shingles in their lifetime, and that shingles can be a painful disease and can have serious long-term complications as well. And age-related decline in immunity and immunocompromise increases shingles risk. And the burden of shingles increases as persons age, with a steep increase in those who are 50 and above. Shingrix is designed to help protect against shingles, delivering more than 90% efficacy against zoster in those 50 years and above. And 2 doses of the vaccine are indicated for adults 50 and above. So have you been vaccinated against shingles yet? If not, please lead by example and be a role model for your patients. With that, I thank you very much for your time. Thank you.
In a few moments, I'll get Dr. Asok to join me here on the podium. In the meantime, I'll encourage the audience who are with us to send their questions in. So thank you very much, Asok. Since you spend so much time on the side effects of the vaccine, let's go there first. In your personal experience, what is the most common side effect that you have seen amongst your patients who have received the Shingrix?
Yeah, thanks for the question, Jasmin. Can you hear me?
Yes.
Okay. So, well, in my experience, it has been pain. So that can be quite, not, I wouldn't say debilitating, but it's something that is quite common.
Mm-hmm.
So quite a lot of patients experience that. They also feel tired. They have this fatigue syndrome as well, headaches.
Mm-hmm.
So I think those are some of the more common ones.
And how do you advise them to overcome these side effects of the vaccine?
Well, we tell
What
them
works?
not to strain or stress themselves. I think people have already understood some of these advisories from the COVID-19 story, vaccine story.
Mm-hmm.
So people say, okay, you got to chill after the vaccine. Don't go for your marathon run, bungee jumping, you know. So take a few days, not that you don't have to take work off, but you know, you don't do rigorous or strenuous exercise, hydrate well. So simple measures like that can go a long way.
Yep. Of course, if once bitten, twice shy. So
Yeah.
if you have bad reaction from the first vaccine, what happens with the second dose? Is it better? Is it worse?
No, it's about the same. Sometimes it's not the same at all. Okay, I haven't seen an amplified risk as a result of the second vaccine. We do still advise and inform patients that they might get the reaction, but not in a way that may be exacerbated or go into some serious effect just because they had been out of action or out of commission for 1 or 2 days after. So we tell them that the vast majority of instances are low grade, sustainable, something that can be overcome. And we, in my practice, since you asked, I've given quite a few now, and I can tell you that in my context, but of course my caveat is that I come from a different zone from you. It's much more easy to get compliance.
Right.
Okay, because there's a cost involved and so on. So people have not been coming back. The only reason they have not sometimes is because of all these questions about the COVID-19 vaccine, so that kind of thing.
Right.
Some people, of course, we started this fairly recently, so we haven't had a lot of overseas patients. So the forward challenge for us in the context of our medical tourism will be some of these patients who come and they go and they come back again. So sometimes it may not be so easy for them to come back because of all the restrictions, and so this can be quite impactful. But if it's available in their home country, then that makes it easier.
Right. You know, you talked about the impact of COVID-19 on your patient, and clearly there is a cost benefit ratio in a sense that it helps them feel better, reduce the side effects or the debilitating effects of shingles, to help them not get shingles so that they can stay healthy and active. And so
Yeah.
very often people don't see that benefit of having the vaccine early, and there's a cost investment and a benefit
Yes.
there.
Yes.
Yeah.
True.
Yeah, so I like that point.
Totally right. So you need to kind of let them look into the crystal ball a bit.
Mhm.
Sometimes you tend to play it. I'm not being dramatic, but that story about wanting to take a break and a holiday and not wanting to get a zoster, during the time when you are taking a break. People think, I'm not stressed, I'm on holiday, why am I getting zoster? But it can happen,
Yeah.
Yeah.
Yeah. So, because shingles is so common, what happens if patients have shingles previously? Do they still qualify for this vaccine?
Yeah, so that's a good question, Jasmine. And I wonder whether I have the liberty of going back to my slides, showing
Sure.
you something,
Yeah.
because I thought that you might ask this question. Oh, sorry, can I? Okay. So the first part of it was what Jasmine had asked. So can I vaccinate someone with Shingrix who already had shingles? So there's limited data to support the use of Shingrix in individuals who had herpes zoster. But healthcare providers can, and you can weigh in the benefits and risks of the vaccine on an individual basis. There has been a phase 3 open label clinical study of approximately 100 adults who are 50 years and above with a history of zoster who received 2 doses of the Shingrix 2 months apart. And there was some immunogenicity that was seen. The vaccine response, as measured by the anti-glycoprotein E antibodies at 1 month post-vaccine, was about 90.2%. Now, our question always becomes, if someone has had zoster, when can you give the Shingrix vaccine? So there is no hard and fast rule. It belongs to the opinion of, well, it's an expert opinion domain. So with regards to our local infectious diseases society, the guidelines state that there's no length of time that one must wait, but please ensure that the shingles rash has disappeared before getting the vaccine. So variably in other countries and other institutions, they have done 6 months to 1 year. So that's kind of where you can give the vaccine. If I may, Jasmine, can I take the liberty of going through 2 others since they're on the slide and
Sure,
on
go ahead.
everyone's minds as well? So, well, so can patients who have previously received the zoster live vaccine, because some of us may have received it, can we receive Shingrix? Well, the answer is that patients with zoster vaccine previously were precluded in the pivotal efficacy trials, but Shingrix vaccination administered more than 5 years after the live vaccine has been evaluated in clinical trials. The immune system, the immune response was unaffected by prior live vaccine administration. So Shingrix can be given with the same schedule in individuals previously vaccinated with the live vaccine. But unfortunately, the company has no data for the use of Shingrix less than 5 years after the live vaccine. I suspected that people might ask about boosters since we are in a world where we are boostering away. So is there a booster required for Shingrix? Let's take that out of the way. The need for the booster doses has not been established. And Shingrix currently has efficacy and immunogenicity data, as alluded to earlier, for up to 7 and 10 years respectively. Thank you.
Ashok, I have more questions for you, right? Yeah. So just riding on the COVID wave and the COVID vaccination wave, these are questions to do with the immune responses and vaccine efficacy. Everybody talks about antibody titers and antibody levels. There is a question from the audience. Catherine would like to check if a person's VZV IgG is high. What does that mean for them? Is this person still at risk of getting herpes zoster? Any comments?
Yeah, just like the same COVID-19 experience as well, since we are riding that wave, we can't say that there is a defined correlate of protection when it comes to the vis-a-vis antibody titer. There is more to Mother Nature and the complexity of both the adaptive immune system and cell-mediated immunity that we cannot identify or detect with antibody tests per se. And none of the commercial assays can give us that kind of robust conviction. So I will not make any kind of prediction based on the antibody titers.
So would it be right to say that you wouldn't even check antibody titers?
Yeah,
if
there is no need
yeah.
to check the antibody titers in an individual whom you're planning to give the vaccine. The vaccine has been given, of course, not planned, but in people who never had shingles, chickenpox before, there's been no unintended consequences.
Mm-hmm.
Actually, there might be some protection against chickenpox as well. You know, that's not the primary intention of the vaccine, but it is kind of like a little beneficial collateral, if you will.
Right. So on vaccine administration, more questions, Ashok. On vaccine administration, there are 2 doses. The second dose is recommended between 2 to 6 months. So there's a question from the floor asking, is there a preferred interval? Why such a range in timing for the second dose?
Yeah, so there's this time beyond which there's not much data. I think in the context of clinical, the pivotal studies and other kinds of data that was there prior, this is the safety. This is not the safety. This is the time period that has been studied. So if you were to give the vaccine, get the vaccine, and then subsequently you forget or for some reason you don't want it, and then at a later time, maybe some 9 months later, you want to think of getting the vaccine, you don't have to redo the series. You can just get the second dose. However, the caveat is we don't know the true efficacy of that, but the recommendation is just to get a single dose. However, if you were to give the vaccine too close, like say, for example, you got it 3 weeks apart, then you need to redo the second dose.
Right.
Yeah.
Okay. And still on the subject of vaccine administration, are there larger immune responses with the co-administration of Shingrix and unadjuvanted vaccines?
I don't know that that has been actually studied.
Right.
Yeah, you know, so that's an interesting concept because you're giving unadjuvanted or adjuvanted. Because we don't say give it with adjuvanted, we just want it with unadjuvanted.
If I interpreted the question right, I think it's talking about Shingrix vaccination, co-administration with other vaccines. Maybe if I could phrase the question slightly differently, are there any rules or principles that you use? Because you're going to see the doctor. Do you get 1 shot or 2 shots? Do you get all of them at one go?
There is safety data co-administration with the pneumococcal polysaccharide vaccine 23. The 23-valent vaccine. There is also data for the Tdap. And so these are the usual ones where and flu, so these are the typical vaccines that you can actually give co-administer with no issues, the flu vaccine being one that is not adjuvanted. But I don't know whether I read the question about boosting the immunity per se, because there's no data for boosting the immunity in the context of that you're going to get more bang for the buck by giving it with some other vaccine, if I understood the question.
I'm with you, Ashok, but I think perhaps the idea is that you can give it with other vaccines at the same time.
So you can, yeah. So I think that there will be this lost opportunity if you were to try to think, oh, let's defer it with this vaccine and that vaccine, because individuals who come to you who are persuaded to get a vaccine, it's a good opportunity for you to give them, not to say you crank them up with all kinds of vaccines, but that's a good opportunity for you to give them whatever vaccine that is best suited for them, because they can't go and come, especially elderly patients who need caregivers and with all these restrictions. So we want to experience some science and some common sense with regards to these things. And as we know with COVID-19, that is also probably slowly evolving as well, right? Where did this 14-day thing come from? But I think it's more policy rather than science.
Yeah, that's true too, Ashok.
Yeah.
So now you have convinced the audience that they're going to get the Shingrix vaccine.
Have I convinced you? You don't need the vaccine yet.
Not yet, but let's talk about the question first. So now that they're convinced that Shingrix is the way to go, they want to comment. Could you comment on the possible correlation with GBS, Guillain-Barré syndrome in the US with this vaccine? Is there anything to be concerned about?
this came from the FDA alert. There was excess risk. This is a post-marketing surveillance. I mean, this is true for a lot of vaccines in the context of what has been studied in pivotal studies and what happens in the real world. Because when you give it to literally millions and millions and millions of people just with the COVID-19 vaccines, you may not pick up that signal when you do your studies, but you may pick it up subsequently. And this is actually a testament to the very good pharmacovigilance and other kinds of surveillance that goes on. So you can pick up tiny signals like this. I don't think the data is so convincing yet. There's been some 3 excess cases per million, if my stats correct. So it's something like a early, maybe something like a little signal. So you would want to perhaps engage a little discussion with patients who have had Guillain-Barré before, that maybe they are currently precluded until we have more information. So it doesn't apply to other kinds of neurological conditions, just this aspect on Guillain-Barré.
I'm going to bring you back to topical issues again, Ashok. COVID is haunting us, and now it's back to haunt you on stage.
You are chewed up by COVID, aren't you? Yeah, we need a support group, because so am I.
Right. Let's talk about COVID-19 vaccination and shingles reactivation. And it so happened that you had a slide on shingles and COVID vaccination. Could you just put things in context for us? Because,
there is yeah, because COVID-19 infection, right? You're not talking about the vaccination?
Both.
Both, yeah. I don't think the signal is so much with COVID-19 vaccination and herpes zoster reactivation. There's not a big kind of situation that I can see, and that's not my experience either. And I don't think that has been detected on HSA's count as well. But in the context of COVID-19 in itself, then that's a possibility, because there's a lot of immunomodulation that occurs in the course of COVID-19. So it's not just the disease itself, but sometimes the therapies, like for example, in some cases you use drugs like tocilizumab and so on. So that may actually, as a bad collateral, beget some complication like zoster. So I don't put that out of the way. So there is that kind of contextual approach. So if there is a lot of COVID going around and we want to protect ourselves in the best possible way, now is better more than ever to think about getting the Shingrix vaccine as well. So there's one thing up for Shingrix in that question.
Okay.
I don't know whether you are going to ask me this question, because I know your background is in immunocompromised, and maybe it's at the back of your head, so I shall just pull it up to the front, okay?
Sure, Ashok,
Should you
ask
bare
my
your
question.
soul to the, so I think what I'm asking aloud, if I may, is that whether or not this vaccine Shingrix is endorsed, approved, or something that can be considered for people who are immunocompromised. Because obviously the issue with regards to the live vaccine, as I alluded to, is that it's actually is a contraindication. But currently the indication locally in Singapore is only for people who are immunocompetent in the context of what we discussed. Of course, comorbidities, that's not considered immunocompromised, but not the specific immunocompromised patients per se. Having said that, there is actually some data that's evolving, including that's been endorsed by the US Food and Drug Administration in regards to individuals who are autologous hematopoietic stem cell transplant, where they used this vaccine and they found that actually the efficacy of preventing zoster was to the tune of approximately 68% or so. So I think that the US FDA has approved that based on the indication for that group. But I think that the ACIP, which is the formal policymakers, have not adopted that yet, even in the US. So we stay tuned to that. There is a lot of immunogenicity data that looks very promising in the context of renal transplant patients, patients with HIV, and so many other contexts. So I think that's something we would like to stay tuned to.
I'm sure once the studies have been reviewed and the drug has been approved by various authorities outside of US and Europe, it would benefit a large group of our patients, especially the immunocompromised
certainly. Yeah, I think we do want to protect them, because we just alluded to the fact that they're at higher risk.
Yeah. So, apart from immunocompromised state, there's this concept of immunosenescence. There was a question regarding immunosenescence. What are your thoughts on immunosenescence in the current COVID-19 COVID-19 mRNA vaccines?
Hey, that's a COVID-19 question. How did that sneak up there?
Well, I suppose the concepts are similar, right? Just bringing the topic, if there is immunosenescence, your immune system is not working so
Yes,
well.
exactly right.
Yeah.
So, I mean, I think that is the problem with our local epidemiology, where those who are above 60 and above start to get very heightened risk. In fact, just like how the precipitous risk for shingles appear at the
Yeah.
50 and above, so the same holds true for COVID-19.
Yeah.
In that is a lot of similarity.
Final question from the audience. I'm not asking about COVID-19, it's about immunosenescence. Do we know of any studies looking into the mechanistic basis behind it? Do you know how it happens for
From
immunosenescence?
Well, I think it's the cell-mediated immunity, because that's reasonably robust when we are presumably young and youthful and energetic, like your good self. And so when we get, older, and then that there is that kind of age-related decline in the cell-mediated immunity. I think it's mainly cell-mediated immunity rather than the B cells.
The
They're
antibody.
antibody driven, because I think, and you may know this as well, that those patients who are hematopoietic stem cell transplants and post-transplants, when they actually have got their immune system wiped out, they get immunoglobulins, etc. But then they are still at risk for zoster because they just don't have their T cells playing out. And for all the childhood immunoglobulopathies, those kids are also having a lot of issues with B, but that's not a big signal by them getting zoster. So I think this is kind of a testament that we are mainly dealing with cell-mediated immunity by way of immunosenescence, and that you want to actually perk that up, and in the good adjuvant system, which has a collateral of a lot of vaccine. Probably it's that rather than the glycoprotein, but whatever, you got this local reactogenicity as a side effect. But nonetheless, you can boost that cell-mediated immunity, and that's the principle behind this.
Well, thank you, Ashok.
We are done. Are you done?
I've learned a lot from you once again, so thank you very much,
Sure, it's my
Ashok.
pleasure. Yeah.